Dr. Thomas, and also the organizers for giving me the opportunity to present regarding the CAPTAIN trial on behalf of the CAPTAIN trial member states. I do have a few pertinent disclosures in this space, especially clinical trial support from a few different companies. So the rationale for RCT, as we know from our AUA guidelines as well as commercial payers, there's this request for RCTs for long-term outcomes to establish kind of comparing ablative therapies to standard of care with surgery or radiation. There have been multiple kind of RCTs in this space that have failed in the past. Recruitment mainly due to lack of equipoise, and as well as the kind of difficulty of patients wanting to be randomized between ablative modalities and radical treatments. We know from the TAP trial that Tulsa has proven safety and efficacy for whole gland ablation for intermediate risk prostate cancer, as well as a comparable timeline for safety and efficacy events comparing Tulsa and surgery. So these are all kind of factors that foster equipoise, and I think is a great kind of background to why we're doing this study. So there's a total of 23 different sites across primarily the U.S., but as well as internationally, of which both there's major academic centers as well as large local centers. This was the initial kind of RCT design. We were looking for 201 patients with organ-confined intermediate risk prostate cancer. It was a 2-to-1 randomization with 2 patients out of every 3 getting Tulsa and 1 out of every 3 getting radical prostatectomy, as well as our outcomes. Looking at the 1-year endpoint as a percentage of patients that are PAD3 continence, as the directional penetration, and a 3-year efficacy endpoint, looking at the percentage of patients who didn't need initial intervention for prostate cancer, as well as meant for prostate cancer death. Of note, if you were in the Tulsa arm, you were allowed 1 additional round of ablation within the 12 months. So here's our study schema. So as expected, most of these focal therapy trials are within patients with intermediate risk disease. One of the things that's a little bit different about the CAPTAIN trials, we're allowed for multifocal disease. So you were allowed to have 2 or 3 different sites of intermediate risk prostate cancer. PSA to be less than 20 with no EPEM imaging. The other inclusion criteria are more specific to Tulsa. They had to be within 3 centimeters of the urethra, given the Tulsa technology. They couldn't have large calcium deposits, as well as any implants that affected, that could cause MR artifact. So I'm happy to say to date, we've actually randomized over 201 patients. We are continuing randomization, so we get to 201 patients treated. If you look at our study scheme, we've actually randomized 226 patients. Out of them, a few patients have kind of pulled out of the Tulsa arm, as well as 25 patients have been have kind of refused to proceed with their allocation of radical prostatectomy. Looking at our official patient cohort for our interim analysis, you can see these groups are well balanced. The only exception to this is there's actually a higher proportion of African American men who've been treated within the Tulsa arm compared to radical prostatectomy, but everything else in terms of grade group and stage is unbalanced. In terms of initial perioperative outcomes, we can see that Tulsa has a significantly less blood loss compared to surgery during treatment, as well as a significantly shorter periprocedural length of stay. Some of these patients were treated in an ambulatory surgery center or imaging center, but some of these patients are treated in hospital setting as well. Every patient fills out a 30-day post-treatment questionnaire to look at kind of quality of life after surgery or Tulsa. And you can see, especially in the first 6 days, there's a significant difference in the pain scale after treatment, favoring the Tulsa arm. Additionally, in the right half of the diagram, the lower scores are better, so you can see that significantly less patients have effect on their quality of life, whether it's their mobility, their ability to do their normal activities, as well as pain and anxiety after treatment. Additionally, we kind of look at the change in overall kind of health score after treatment. You can see after surgery, there's a significantly larger drop in terms of overall health score with kind of slow recovery. And it takes on average, about 2 weeks for the surgery arm to kind of reach where the Tulsa patients are right after treatment. So, in conclusion, the CAPTAIN trial really has the potential to report the first level 1 evidence of safety and efficacy for ablation versus prostatectomy and intermediate risk prostate cancer. I think Dr. Gill brought up this good point earlier that there's really a lack of these kind of studies in the U.S., and we hope to fulfill this kind of a important trial in this space. This is the first RCT in this space is successfully recruit to target with a few ongoing randomizations to get to 201 patients treated. Initial outcomes really demonstrate that Tulsa has got a minimal blood loss, less overnight hospital stay compared to surgery, along with reduced post-procedural pain and more rapid recovery to baseline and overall health. And the expected kind of 1 year efficacy and safety outcomes, as well as the 3-year efficacy outcomes, will be reported in the near future, the next few years. Be happy to take any questions.